Good evening, everyone. Welcome to Pediatrics Made Easy by Dr. Mayank Pahuja. Today, we'll be discussing about insulin therapy in children. I intentionally made this presentation or chose this topic of insulin therapy because most of us as pediatricians or as postgraduates or as interns, they feel very easy to start insulin in children, and most of the time we start insulin when we get children in diabetic ketoacidotic state in emergency. But what happens or where we feel difficulties, what after that? So so basically, when do we start insulin? It is diabetic ketoacidosis, or the patient most of the times meet you in a ketoacidotic state where you start with insulin therapy. And 90 to 95% of us as doctors or pediatricians, it is very easy, or we know about the protocols of diabetic ketoacidosis, how much insulin to start as insulin drip, but we fall short of knowledge, or we are not confident enough to what to do after this, treating this deep DKA episode. So my presentation focuses on what to do after post DKA management of diabetes, which insulin to use. So by the end of this presentation, you people should know which insulin to use, how to use, which regime to use, single or multiple types of insulin, and how many times a day that insulin is required. So starting with the first question, which insulin to be used? So this table seems to be very difficult, but at the end of this slide, I'll be very sure that you people won't be finding it a very difficult slide, and you will be knowing about all the types of insulin. So just to start with, I'll be first telling you about the types of insulin. Basic types of insulin we should remember in practice. They're rapid acting analog, short acting analog, intermediate acting human insulin, long acting analog, and ultra long acting analog. So basically, from the name itself, the rapid acting analog means it acts very rapidly. That is based on onset of action. Okay. Short acting human insulin, if we'll see, it starts acting little bit late after the rapid acting. So as of now, we should know the names of categories. They are rapid acting insulin analog, short acting insulin, human insulin, intermediate acting human insulin, long acting analog, and ultra long acting analog. So coming on to the types or the examples of these categories of insulin, just to remember, rapid acting analog, it is lag. We can remember with a mnemonic of lag. So lag is rapid acting insulin, and lag stands for lispro, aspart, and glulicin. In practice, we most commonly use only two types of rapid acting analog, that is lispro and aspart. Next comes the short acting human insulin, and the short acting human insulin is the nothing but regular insulin. And if we talk about intermediate acting human insulin, they are NPH or Lente. Coming on to the long acting analogs, they are glargine and detamir. But most commonly we use these days is glargine, and ultra long acting, if we try to see, it is degludec. So for all practical purposes, we need to remember only two types of rapid acting analog, that is lispro and aspart. Regular insulin as an example of short acting human insulin. In intermediate acting, we need to remember NPH and Lente. In long acting analog, we need to remember glargine, which are most practically used. So let's see, coming on to the onset of action. Onset of action means after giving insulin, after how much time will it start acting? So if we'll see, it is given in this table, it is given in hours. See, these types of insulin or these types of table you will get in almost all the common on the famous books. You can get easily there. So if we'll see the onset of action, we can clearly see the rapid acting is acting in first 15 minutes. So it is 0.25 hours, that is first 15 minutes. It acts within 15 minutes. And short acting insulin, if we see, it acts within half an hour to 1 hour. Okay, half an hour to 1 hour. And if we see intermediate acting human insulin, it is acting between 1 to 3 hours. Long acting insulin is taking time of 2 to 3 hours to start its action. An ultra long acting analog is taking half an hour to 15 hours, 1.5 hours. That is half an hour to 1.5 hours. So this is the basically after giving insulin injections, after how much time will it start acting. So importance of this on knowing this onset is before you have to decide before that you have to keep a meal ready for diabetic patients when they take insulin. So it is very important, if you are giving rapid acting insulin, you should know in mind that yes, your patient is taking lispro insulin, so your insulin will be acting within 15 minutes. So you should give injection before 15 minutes before to your breakfast time or your pre-meal time. Whatever time you are giving a meal, you should give it insulin. If you are giving it rapid acting insulin, you should give 15 minutes prior to that. So that there lies the importance of onset of action. So suppose, for instance, you are giving regular insulin to your patient in pre-breakfast, and you give insulin, suppose your breakfast time is 8 o'clock and you give it at 7:45. So there lies the importance. You should give insulin at 7:30 and your breakfast should be ready within half an hour, or your patient should start taking breakfast within half an hour. So there lies the importance of onset of action. Next, coming on to the peak. Peak means when is the peak maximum action or maximum levels of insulin in our body. So if we talk about rapid acting insulin, it is 1 to 3 hours. Peak comes in 1 to 3 hours. So it is like that. You inject insulin. Suppose you inject insulin here, and your action, this is the onset and this is the peak. Okay, and after that this comes like this, level of insulin comes like this. So this is the peak of rapid acting comes at 1 to 3 hours, short acting comes at 2 to 4 hours, and intermediate the peak is at 4 to 8 hours. Now it is very important to know, in long acting insulin glargine, which is most commonly used, there is no peak. Yes, so there is no peak in glargine, which is a long acting analog, and there's a peak of 3 to 9 hours in detamir, and again there is no peak in degludec. Coming on to the duration, for how much duration your insulin is acting is also very important. Suppose your rapid acting insulin, that is lag, lispro, aspartame, luricin, it acts for a period of 3 to 5 hours. Okay, so that means after 5 hours you need another insulin. For if the patient is having anything, your body needs another insulin to take care of the blood sugar levels. Coming on to the short acting insulin, the duration is 6 to 8 hours. Intermediate acting human insulin, it is 12 to 16 hours. You can see by name, again you can remember with its name, intermediate acting. It's somewhere between long acting and rapid acting insulin. So it acts for a period of 12 to 16 hours. And long acting insulin, it acts for almost 16 to 24 hours, and ultra long acts for more than 24 hours. So again, what is the importance of knowing this duration? If when we'll be discussing about insulin regimes in the further slides, then it becomes very important, and then if we know this duration, it becomes very easy for us to choose insulin. Why this insulin is choose, why there are 3 injections, so that there lies the importance of knowing the duration. I'll be discussing in the further slides. Coming on to the insulin regimes, so basically there are 2 regimes: split mix regime, that is conventional, and the basal bolus regimes, that is IIT, intensive insulin therapy. So basically there are the two major regimes you need to know at this stage, and two regimes are split mix and basal bolus. So split mix regime is conventional regime, and basal bolus is the intensive insulin therapy, and we should know it is more physiological. Okay, split mix regime. What we are doing in split mix regime, we are calculating the total daily dose of insulin, and we are dividing into either two parts, either pre-breakfast or pre-dinner. And what we are doing in basal bolus regime, that is more physiological. We are giving two types of injection. One is basal and one is bolus. What is basal? One insulin is there which is present 24/7 in our body, which maintains the basal levels in our body. And bolus is for each meal we give out another insulin that is taking care of that particular meal. So that is basal bolus regime. And in split mix regime, we are giving a combination of two types of insulin. We calculate the total daily dose and we give in two divided doses. How we give, we'll be studying in the further slides. So now we see that these two regimes are there. We already studied the split mix regime and the basal bolus regime. So if we can clearly see, so there are two types of regime, two types of option in the split mix regime, which are given in this table. That is 2 injections per day and 3 injections per day. Okay, so if we see here, what we are doing in the pre-breakfast, what we are doing, we are taking one human irregular insulin, and another we are taking rapid acting analog, either one of them, regular insulin or a rapid acting analog, that is lispro as part of glucin, and one NPH. NPH is, see, NPH is intermediate acting, and if we see, we are taking either a short acting, that is regular insulin, or a rapid acting insulin, that is lispro and aspart or glucin, and a intermediate acting, which is NPH. Okay, we are giving it in pre-breakfast and we are giving it in pre-dinner. So the combination of a short acting or a rapid acting insulin along with intermediate acting insulin. In we see, we a second type of split mix regime, we are giving 3 injections per day. What we are doing, in what is the difference between these two regimes in a 2 injection per day and a 3 injection per day? This is same as in pre-breakfast. This is in pre-dinner. What we have done, we are not giving NPH here in pre-dinner. We are giving NPH separately at bedtime. So logic behind this, in this split mix regime and a 2 injections per day and 3 injections per day, difference is we are giving an intermediate acting insulin at bedtime. So logic behind this is, I'll just tell you with a graph after this slide. And in basal bolus with human insulin, what we are doing, we are giving 3 injections per day or 4 injections per day. So if we give 3 injections per day, they are human regular plus NPH, that is again same. We give separately a bolus of pre-lunch, and we give a bolus here again of regular insulin, human regulars in pre-dinner. So 3 regular insulin 3 times a day, and which is pre-breakfast, pre-lunch and pre-dinner. So this is a bolus, and this NPH given at pre-breakfast or pre-dinner. This NPH is again, if we'll see this table, NPH is acting for how much duration? It is acting for 12 to 16 hours. Suppose it acts for 12 hours. This NPH given in morning will be taking care of the blood sugar levels from morning to dinner, and from dinner, this pre-dinner dose of NPH will take care from blood sugar levels from pre-dinner to breakfast levels. Okay, and in this 4 injections per day, what is happening? Everything is same in from the above one. What we are doing here, again human regular as a bolus, and NPH here again human regular, again human regular, but we are not giving this NPH here, we are giving it at bedtime. So it becomes 4 injections per day. I'll be coming on to this, that why this bedtime is being given separately. If we discuss about this basal bolus with insulin analogs, what it is being done, a rapid acting analog, a rapid acting analog, rapid acting analog as boluses, and this glargine, which maintains, there is no peak, it maintains a basal levels and works for 24 hours. Okay, so this glargine is working for 24 hours. That is why it is given at bedtime. It is long acting. So pre-breakfast, breakfast sugar levels will be taken care of by rapid acting analog. Again, pre-lunch will be taken by care by this rapid acting analog. Again, pre-dinner the blood sugar levels will be taken, and throughout there will be a basal level which will be maintained by glargine. And in this 4 injection level with human insulin and this NPH, the basal levels are being taken care of by NPH from morning to night, and this NPH from night to morning. Coming on to this basal bolus regime with insulin analogs, again a rapid acting analog, a detamere injection, okay, which is again a peakless insulin type of ultra long acting, a rapid acting analog, a rapid acting analog, detamere air. Okay, so two types of detamine. Most commonly, which we are using these days, this is this regime of basal bolus. Now, coming on to the concept, why this is being given at bedtime, if we see, there's a split mix regime, okay, like this. So what happens, we are giving a human regular combination of regular or a rapid acting with NPH. So what happens, we give 2 injections here. There is for a pre-breakfast, if we see, it acts, sorry. So pre-breakfast, if we see, we give insulin like this. So this is peak, this is regular, okay, and this is NPH. Okay, what is happening? This is pre-breakfast. If we see this one, okay, and here we give pre-dinner this one. So they are again 2 peaks. So NPH peak, and again we are seeing this is a regular insulin. So if we see, basically there are 2 peaks, pre-breakfast and this is pre-dinner. What is happening? We are giving one regular insulin and one NPH. Okay, NPH. What is happening? It is regular insulin is short acting insulin, and this NPH is a intermediate acting insulin. What is happening? We give both of them. Regular insulin takes care of the breakfast blood sugar levels, and NPH is little bit long acting, which takes care of what we eat, what their pre-lunch or the lunch blood sugar levels. NPH takes care of that. So this graph becomes like this. NPH takes care of blood sugar levels still here, and pre-dinner we give again 2 injections like this. So what was happening in this NPH, again 2 peaks of insulin. Here nothing was happening wrong because child was taking lunch here, okay, so no hypoglycemia was there. But what was seen in pre-dinner, this regular insulin and this NPH, there was 2 peaks, and this NPH is acting again for, we can see here very clearly, NPH is acting for 12 to 16 hours, and we are not having anything, child is not having anything till breakfast. So what was happening, this regular insulin was taking care of the dinner blood sugar levels, and this NPH is acting for a longer duration. So it was causing, and a peak was coming here, and it was causing hypoglycemia. Okay, so we're giving 2 injections, short acting and an NPH at pre-dinner. So what was seen, this hypoglycemia was seen at around 2 a.m. or 3 a.m. So which is very important, you should know, 2 a.m. or 3 a.m. hypoglycemia. For that, what we did, we modified this regime into 3 injections per day, and we use this NPH little bit later at bedtime. So now graph becomes like this. So this is pre-breakfast, we didn't touch it. And this is suppose lunch is here, and this is NPH, okay, NPH, lunch is done here, and this is pre-dinner again, regular insulin, which is taking place of blood sugar levels of dinner, and we here we give at bedtime. Now this hypoglycemia was not taking place. So this NPH is given at bedtime, they are not given together. So this is the benefit of this, and logic behind this split mix regime of 3 injections per day. So it is very clear what is different between 2 injections per day and 3 injections per day. We are giving this pre-dinner NPH separately at bedtime. Again, same as the funda with basal bolus regime. What is the difference between 3 injections per day and 4 injections per day? This NPH, which is given pre-dinner, is given separately at bedtime just to avoid hypoglycemia at 3 a.m., 2 a.m. and 3 a.m. Now, most commonly followed regime is this one, and we are giving glargine here. What is happening here? I can see. See, in this basal bolus regime, what we are doing, I just told you glargine, which if given, it is maintaining a peak on, there is no peak, it is a peakless. Okay, glargine is peakless, it is maintaining levels for 24/7. So these are which levels? Basal levels. And for breakfast, for lunch, and for dinner, we are giving 3 types shots of short acting insulin like this. Okay, so this is physiology of or basis behind basal bolus regime of this one. Coming on to the next, so see if we'll see the questions, we have answered which insulin to use, which regime, now single or multiple also we have used, and how much to use. Okay, how much insulin. So now the question is, what is the dose of insulin? If we'll see the dose of insulin in prepubertal, that is prepubertal children, it is 0.75 to 1 units per kg. Pubertal, it is 1 to 1.2 units per kg. If we are following split mix regime or if we are following basal bolus regime, what we'll do, suppose it's a 10 kg child. Okay, suppose it's a 10 kg child, and if we'll see, and the age and the child is prepubertal, so dose comes out to be 10 kg. Okay, dose come out to be, sorry, dose come out to be 10 units. We have to give 10 units throughout the day. Now what we'll do, if we know that is this is the total daily dose of insulin for a 10 kg child, that is 10 units if he or she is prepubertal. Now what we are doing in split mix regime, we'll see before breakfast and before dinner. Firstly, we'll divide this 10 units, 2/3 and 1/3. So 2/3 will be given up before breakfast, and 1/3 of this dose will be given before dinner. Now what we'll do, we have just done 2/3 and 1/3 of this total daily doses. Now what we'll do, we out of these 10 units, 2/3 of this total daily dose has to be given in pre-breakfast. And out of this 2/3, what insulin we have to do, we have to give a short acting insulin or an intermediate acting insulin that we were using, that is regular or a regular insulin or a ultra short acting rapid acting insulin, Lispro or Aspart we are using, and along with it we have to use an intermediate, that is NPH. Okay, now what we'll do, out of this, here we did 2/3 of 10 units, right? 2/3 of 10 units we are giving 2/3, say this. So it is 2/3 of 10 units we'll be giving here. And how we'll be dividing, again we have to divide it into 2/3, and so it roughly it is 6 units roughly. Okay, 2/3 of this. Now if you'll see, of these 6 units, 1/3 should be short acting or the rapid acting, that is the regular insulin or the Lispro Aspart or Glulicin. 1/3 this, and 2/3 is NPH. So we have to decide the doses of insulin like this. We have decided the type of insulin. Now we'll be deciding the doses. So 6 will be again 1/3 and 2/3. So it will be just like 2 units of this, and remaining 4 units will be intermediate acting like NPH. Now remaining though is what 6 units here. So it was 4 units here before dinner it has to be given. Now 1/3 or half as a short acting insulin again, and 2/3 we can do it as 1/3 or 2/3, or we can do it as half and half. Why half? I'll be telling in further slides. So now if we see, 1/3 short acting and 2/3 as intermediate acting. Okay, so roughly we can say 1 and 3 units. If we'll say it is short acting or rapid acting, that is again regular insulin or regular insulin or the rapid acting insulin, that is Lispro as part, and 2/3 as intermediate acting, that is NPH. So here, this is how we divide total daily doses in split mix regime. Same is the bowl based regime. Suppose it is 10 units. The total daily dose is same, calculated by this dose only. So it is again 10 units for a 10 kg child, and we have to decide amongst long acting insulin and short acting insulin. We were giving 3 boluses of short acting insulin, just like Lispro or Aspart, and one we are giving long acting insulin. So what we do here is half of the total daily doses, okay, half of the total daily doses should be glargine. Suppose so it was 10, so it is 5 units of glargine, and short acting, it is 5 units of short acting, suppose Lispro, and we divide. What we do now, we divide it into 3. So roughly 5 is divided into 3 parts, and we give in pre-morning, pre-breakfast, and sorry, pre-breakfast, pre-lunch, and pre-dinner. And glargine we give it 5 units at night. Okay, so this is how we do the division of this doses. In the basal bolus doses, 25 to 30% of total dose is given in toddlers, and 40 to 55% in older dose. That there lies the reason, given at bedtime. Okay, basal dose, that is glargine, and okay, basal levels which is maintaining. So we are giving less dose of glargine, that is long acting, in toddlers, because these toddlers, they have less control of their meals. They take multiple, they sleep in night, and they take multiple times, they take milk, they take multiple means. You cannot control their diet very strictly, so they take multiple, they eat more in daytime. So we give less dose of glargine at night, and we give more dose of boluses in daytime, right? And 40 to 50%, that is half and half doses divided in older children given at bedtime. So this changes in toddlers. This changes in toddlers. This half is changes to, we use 30%. Okay, and rest is 70% is given at short acting, divided into 3 doses in toddlers, case of toddlers. Okay, now coming on to bolus, and the remaining doses were into 3 pre-meal doses. The mealtime prandial doses limit the post-prandial hyperglycemia. Coming on to the RBS monitoring, yes, this becomes very important. We people as pediatricians, because manage these cases, are very, we don't manage very frequently these diabetic patients. We don't get too much as compared to other system cases. So what we do, we should follow this chart of basal bolus and split mix regimes. The area which I have ticked in this table, there needs to be, blood sugar needs to be done, and there is no need of pricking children all the time at 3 a.m., at pre-breakfast, at post-breakfast, pre-lunch, post-lunch, pre-dinner, bedtime, and at last comments. So this sort of table you should make. You should call patient once the blood sugar are stabilized and the dose is titrated, staying in hospital. Then you need to give this sort of table to your patients, and they need to do blood sugar at these point of time only, where there is tick in these boxes, because you should already, there are so much pricks to the children with insulin, either it is 3 or 4 times a day. And if you start pricking for this blood sugar levels also, the child will get irritated. It's not that easy to get so much pricks in a day. So you should know, you should not do all after each and every meals. You should give this chart. So it is after a week, it will give you a blood sugar, complete control of blood sugar at a glance. You can see how the blood sugar levels are being fallen here at a glance. Some there are readings of 3 a.m., sometimes there is pre-breakfast. So overall, after a week, when you see this patient, even same as in split mix regime, after a week when you see this patient, you will have a view at a glance. You could get an idea, okay, now how there were blood sugar levels, it's okay, somewhere it was there, suppose it was 125 pre-breakfast, and if you want to know कि 3 a.m. पे hypoglycemia तो नहीं हो रहा, so then at that place you will see blood sugar being done on Wednesday and Friday. So like this, so you'll get all readings, all sort of readings at all times after a period of 1 week. So this gives a better view and with lesser breaks. So with this, I would like to finish this insulin therapy. I've tried to make it very short. Yes, very short, so that you should remember the practical points and the practical tips. And these are the target HbA1 levels and the blood sugar levels we should try to keep for a period, for an age group of less than 6 years, for 6 to 12 and 13 to 18. These are the target HbA1c levels which we should keep. Yes, HbA1c levels tells us about the control of how the blood sugar is controlled in previous 3 months, and our target should be based on keeping HbA1c levels like this. And this is the bedtime and 3 a.m. blood sugar levels which we should keep it a target, and these are pre-meals levels. So this is as per the 2016 American Diabetes Association. We should try to follow this. Yes, and we should and there is a comment column also. If there is any hyperglycemia, if there's any shoot of blood sugar, or your patient should mention in this chart. Yes, and for this insulin dose needs to be titrated also. This has to be individualized as per patient, which comes with practice. So by this, I'll end my presentation here. Any doubt you can ask in the comment section. And yes, this is all about insulin therapy.